Hello, good morning and good afternoon, dear speakers and guests. I'm Zhofeng Zhang, Associate Dean for Research, UCLA Fielding School of Public Health. I would like to express my warmest welcome to all of you for participation in this Association of Pacific Rim Universities Crisis Management webinar. This is the first webinar led by the UCLA Fielding School of Public Health with a strong support from our Dean, Ron Brookmeyer, and in close collaboration with the Crisis Management Task Force from 4 APRU universities, including Beijing University, National University of Singapore, University of Sydney, and the University of California, Los Angeles. Please note that the webinar is being recorded, and a link to the video will be on the APRU and the UCLA Fielding School of Public Health website in the near future. As for today's schedule, we will have some short opening remarks. Then we will have 5 speakers. Each speaker will provide a 15 minutes presentation. At the end of our speaker presentations, there will be a question and answer session, and you can submit questions at any time during the webinar by click on the Q&A button on your screen. However, due to the time constraints, we may not be able to answer all of your questions. To start today's webinar, let's welcome APRU's Secretary General, Chris Chen-Wang, to represent APRU to provide opening remarks. Dr. Chen-Wang, please.
Thank you very much, Professor Chang, and my welcome to everyone on this webinar, to this inaugural APRU Crisis Management webinar that's hosted by the UCLA Fielding School of Public Health. And this is the first of 4 in a series of webinars. In response to the COVID-19 pandemic, universities, as you know, have had to move fast. We've had to manage the crisis by ensuring that staff and students are safe and able to continue with studies and research, despite the realities and necessity for physical isolation. So universities and their experts have been working at the forefront on this, serving their societies through their research and education, and in particular through their schools of public health. Next slide. The sharing of information across borders has been essential to an effective global response. And for this reason, APRU has supported the development of this APRU Global Health Crisis Management Program. And you can see that we have a unique geographical reach. We're an association of 56 research universities around the Pacific Ring of Fire. And you can see that our members have expertise in natural hazards and extreme events, now exacerbated by climate change, as well as pandemics, just from their location. I should mention that the chair of our network is Chancellor Jean Block of UCLA. He is chair of our steering committee and will also welcome you, and we're thankful to him also for supporting this initiative. You can see in our next slide the membership that we have in East Asia, Southeast Asia, Australasia, and North and South America, 56 research universities. And we believe that by acting together on these kinds of critical public issues and challenges to our societies, that we can have a significant impact, and hence this initiative. In response to the COVID-19 crisis, APRU has hosted more than 10 webinars focused on it. We've converted our annual multi-hazard summer school and 2 large-scale conferences on global health and sustainable cities and landscapes. We've converted these large-scale conferences to virtual events. widening their scope and reach. And we've also developed an APRU virtual student exchange because, of course, students can no longer travel at this time, but we still need the stimulation of new social networks and cultural experiences, as well as academic courses online. The APRU Global Health Crisis Management Program was initiated, and we're most grateful for this, by the Peking University School of Public Health, one of our APRU members in China. With Peking U, UCLA, the National University of Singapore, and the University of Sydney, the program now has these 4 core members that are aiming to share their experience of the different ways the pandemic has impacted on their 4 cities and societies. Collaboration on this program offers the opportunity to examine and reflect on each university's responses and each country's or economy's responses to the pandemic, and draw lessons for future public health crises, preparedness, and management. And we will learn about this today as well as in the following webinars. Please explore on our special website, aprUplus.org, what we're doing in a range of activities, virtual events for academics, for students, researchers, in response to COVID-19. Finally, let me thank again Professor Chung, Associate Dean, and Associate Professor Kathy Lang, both from the Fielding School of Public Health, for leading this inaugural webinar. We're most grateful to you. And I also want to thank Dean Brookmeyer and the expert speakers that are contributing today from the universities that I mentioned and from the Chinese Center for Disease Control and Prevention. Thank you for your support, and I'm sure this will be a thoroughly worthwhile and interesting webinar. Thank you.
Hello from Los Angeles. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health. It was wonderful to hear from APRU Secretary General Tremawan. We thank him for making time to share his remarks with us. I want to thank Dr. Zhang, Professor Lang, Ginger Williams, and representatives from APRU for their work in making today's forum possible. And I'd also like to express appreciation to my UCLA colleagues, as well as those in Australia, Singapore, and China who will present during today's webinar. Before we hear from our speakers, I'd like to share a message from the Chancellor of UCLA, Jean Block. In addition to leading our university, Chancellor Block serves as the chair of APRU. And although he was unable to be with us tonight, he was kind enough to record remarks that we will play for you now.
Hello, everyone. I hope you're staying safe and healthy, and thank you for tuning in from several different time zones. As Chancellor of UCLA and chair of the APRU, I am delighted to welcome you to the inaugural APRU Crisis Management webinar. This is a major multinational collaboration between 4 APRU member universities: the University of Sydney, National University of Singapore, Peking University, and UCLA. I'd like to thank our co-moderators from the UCLA Fielding School of Public Health, Dean Ron Brookmeyer and Associate Dean for Research, Zhang Zhoufeng, for leading today's session. And I'd like to thank all of our distinguished speakers for joining us and sharing their expertise. This is sure to be a stimulating and illuminating event that will help us better understand how to respond to the defining challenge of our era. We've all been grappling with the COVID-19 pandemic and its fallout at our universities and in our communities. We've seen varied strategies and experiences, and we've gained insights along the way. One of the real benefits of being part of an international organization like APRU is getting the opportunity to learn from one another. Tapping into the incredible wealth of knowledge in the network is a great way to uncover best practices and make informed decisions about how we face the pandemic and its effects. So again, I thank you for joining and contributing to this important discussion. I hope you'll find it lively and informative, and I do hope that you'll join other APRU sessions in the future. A pandemic is a global challenge, and I'm grateful we have such a close-knit, globally minded group considering how best to address it.
We appreciate Chancellor Block sharing his perspective and framing so well the lessons that we can learn from one another about COVID-19 at this pivotal moment for our global community. In spite of the many losses that have occurred since the onset of COVID-19 and the challenges that still lie ahead, I find inspiration and energy in gatherings like this, with opportunities to hear from colleagues like the ones you will meet tonight. It's my pleasure now to introduce our first speaker, Dr. Zhenyu Wu, Chief Epidemiologist of the Chinese Center for Disease Control and Prevention. Dr. Wu has worked in infectious disease control for more than 30 years, and during that time has published more than 500 academic papers. He was involved in the response to the SARS outbreak in Beijing in 2003, and has been actively involved in the response to COVID-19 in China. Thus far, he has 11 COVID-19 publications. Dr. Wu has received numerous honors over the years, including the 2005 International Rolleston Award for implementing harm reduction in China, and a UNAIDS Gold Medal in 2008. And as an alumna of the UCLA Fielding School of Public Health in 2006, Dr. Wu was inducted into our school's Alumni Hall of Fame. Now, on a personal note, I've had a great fortune to collaborate with Dr. Wu on numerous occasions over the years, including workshops in China and the US, co-authoring journal articles and more with him. Today, he will address recent Beijing COVID-19 outbreak and China's COVID-19 perspectives, and I am delighted that he is here with us today. Dr. Wu.
Great. Thank you for your introduction. Let's share my slides. To join this webinar, so I will present you recent Beijing COVID-19 outbreak and perspective. Let me bring you back to the early events, how China responded to this global epidemic. The last December 27th, initial cases of pneumonia was noticed and reported by a doctor in Wuhan. On December, issued by Wuhan Health Authority. Next day, National Health Commission and China CDC sent an investigation team to Wuhan to assist investigation. Early investigation found high proportion of patients had a common exposure on a seafood market. Next day, the market was closed. On January 3rd, we reported the epidemic to WHO and other countries. When we talk about other countries, that include United States, Japan, Korea, UK, and the European countries. Even we do not know the passage yet. On January 7th, we isolated COVID-19 virus. That isolation, we take a lesson from 2003. We have 4 institutes do isolation independently, include China CDC, Chinese Academy of Medical Science, Chinese Academy of Science Institute of Virology, and also the Military Institute of Medical Science. We reported epidemiology results to WHO on January 9th. On January 10th, RT-PCR test kits was sent to Wuhan for clinical diagnosis. we started to report epidemic to WHO daily. On January 12, we shared the virus sequence with WHO. Then all the countries in the world could take the sequence for develop test kits or for vaccine development. On January 20th, COVID-19 was added to a notifiable disease. On January 23rd, Wuhan city shut down, and the following days, 15 other cities shut down. So I want to review these earlier 3 weeks. Just want to emphasize, China responded very quickly. It only took about 7 days to identify pathogen, only 2 days to develop test kits. So we have 4 very important scientific findings: isolation of virus, and we find the virus sequence and shared with the world. We determined the incubation period. We determined the transmission mode. All these scientific findings laid the basis for control strategy. That's a great contribution made by Chinese scientists to control the COVID-19 in the world. In the early response, we have 2 battle legs. One is we have limited hospital beds. Many people infected cannot admit to the hospital. They continue to spread a virus at home and in the community. Also, we have limited capacity to provide laboratory diagnosis. Address the hospital bed issue, we creatively to create Fangchang Shelter Hospital. That hospital, it's innovative. The major function of shelter hospital is isolation, because majority of patients are milder or moderate. They do not need sophisticated care. And other 4 functions include triage, basic supportive medical care, and daily monitoring and rapid referral, essential living accommodation, and social engagement. Let's update you the epidemic COVID-19 in China. Total, we have reported 85,255 cases, plus 7,926 PCR positive. So our disease report is different from WHO world. For asymptomatic cases, we do not report it as confirmed cases. The overall case mortality was 5.4%. So we have the first epidemic is big in January, February, and it brought under control in the middle of March. And then in the rest of time, the number of cases are limited. A few small cluster outbreak, that's enlarged. To summarize, China will have actually 4 waves of epidemic. The first wave of epidemic is origin from Wuhan and spread to the rest of country. The second wave is imported from abroad, and with a small number of local transmission occurred in the north of China in April and May. The third wave of epidemic, it occurred in Beijing in June. It was very quickly brought under control, less than 1 month. The fourth wave, it's epidemic in July and August, occurred in Dalian and Xinjiang, Urumqi. Now we have 6 weeks, no local transmission of confirmed cases in China. We are prepared for possible 5th wave in the winter. Let's take a Beijing outbreak as an example. So after almost 2 months, no local reported case. Suddenly, on June 11th, a confirmed reported. Then Beijing CDC take quick response. The overall only took less than 1 month. The epidemic brought under control. Let's go more specific. So the overall epidemic only cost 400 one cases, majority in Beijing, some affected in the Xinfadi market, then they went to other provinces, including Hubei, Liaoning. So Beijing's response is timely, fast, accurate, precise, and effective. The first index case, Mr. T, was diagnosed in the morning of June 11th. The epidemic investigation has found he had never been out of Beijing but visited 23 different places in 14 days prior to his diagnosis. Beijing CDC quickly made investigation, collected specimen from 23 places. They find in Xinfadi market, the environmental specimen was RT-PCR positive. Simultaneously, at the same time, a few cases reported had Xinfadi exposure. The local CDC collected more environmental specimen and also tested the vendor in the market. More cases identified. Then the market was closed on June 12th. From the initial index case to the close of Xinfadi market only take 24 hours. That's very quick. All vendors and customers were contained for testing the quarantine. The government immediately responds to the epidemic. They use risk assessment. All neighborhood community were classified into high, medium, low risk area. All close contactors were very carefully identified and quarantined. Only those who were close contactor or had exposed to high risk area were restricted to leave Beijing. Close contacted had exposure to high area were requested for RT-PCR. It's free of charge. Some 10 million people were tested, all confirmed cases, and PCR positive individual received treatment in Yitan Hospital, no single days. So review this response. Beijing took response precisely and put the epidemic in the very minimized unit. For example, the district I live almost have no effect at all. To summarize China's experience, we have 8 lessons learned that include: we respond best-driven, we take core traditional public health measures, we focus on critical battle lines, we use community mobilization and response. It's for the people, by the people. You may remember in the Spring Festival, almost 1.4 billion people have home quarantine for 2 weeks. We respond transparent. We have common communication with the public. Since January, we have a daily conference, press conference to address public concerns. We initiate international cooperation very early. As presented in the first slide, we reported epidemic to WHO and other countries on January 3rd. China had strong leadership and coordination and cooperation. So in the State Council, we have daily meeting to discuss the issues and to coordinate, making sure all support are provided to respond it. And we have a strong logistical support. All of these 8 are critical to respond to COVID-19. That's the end of my presentation. Thank you for your attention.
Thank you so much, Dr. Wu. That was fascinating. And now I'm delighted to introduce Dean Y.Y. Teo of the National University of Singapore. Dean Teo has conducted large-scale genomic studies on populations from Africa, Europe, and Asia, and currently chairs an international consortium investigating the genetic diversity of cosmopolitan and indigenous populations in Asia. Prior to his tenure as dean, Dr. Teo was the founding director of the school's Center for Health Services and Policy Research, and also served as the director of the Center for Infectious Diseases, Epidemiology, and Research. Today, Dr. Teo will address Singapore's response to COVID-19 and mobilizing surge capacity. We're so happy he could be here today. Dean Teo.
Thank you very much, Dean Brookmeyer. And it's a real pleasure to be invited to be part of the inaugural APRU webinar on crisis management. It's a pleasure to be speaking about the COVID-19 situation in Singapore, especially in the way that we have tried to increase our capacity to deal with the crisis in the country. But I think it's important to start off by saying that Singapore, we went through a very painful experience. Our historical context with SARS gave us very important lessons to prepare the country in terms of stockpiling of personal protection equipment, making sure our healthcare workers in the hospitals are all trained and cognizant of what they need to do when there is a respiratory infection, such as the SARS-CoV-2 virus, that it's responsible for COVID-19. So based on that lesson, in Singapore, we have heard from Professor Wu earlier on that China and Beijing in particular has gone through multiple waves. Singapore, we gone through at least 3 waves of importation. The first happened in January, primarily from travelers coming in from China. The second wave of importation came in the middle of March. And actually that arose because of returning travelers, returning Singaporeans from different parts of the world that were suffering from the outbreaks. And right now, Singapore, we see the third wave of importation coming from people who are long-term work pass holders, returning to Singapore to continue working, to continue studying. Some of them carry the infection with them. But if you look at the community cases, particularly at the vertical axis, community cases in Singapore, we have been very fortunate that in the past few months, on average, we see less than 5 community cases in Singapore. The outbreak, the predominant outbreak was really driven by migrant workers working in Singapore, contributing to the development of Singapore, but because they were living in dormitories in much higher density, sometimes 10 to 12 people within a room, that is where that setting was very optimal for a contagious pathogen like the coronavirus to spread. And Singapore right now, we believe that we have managed to curb the infection in the dormitories with a lot of measures, with a lot of manpower and resources dedicated to make sure that the dormitory infections were managed properly. And right now, we are putting in place the necessary precautions to make sure that the infections within the dormitories remain under control. Now, I talk about the migrant workers, and it's important to realize that the spread within the migrant workers happened at their work site, but because of their work site, they went back to their different dormitories, and it spreads very rapidly in a high density living environment. Now, we need to rely on our understanding of the science of the coronavirus, the science of the epidemiology, to really understand what kind of public health policies would be most relevant. And over here is just a very quick stock take at 9 areas where the evidence have constantly been changing and evolving. Whether it is around human to human transmission, right now, if we think back to January, where we think that it is unlikely to be human to human. Even if it is, it's very low transmissibility. Asymptomatic spread is unlikely to happen. But right now, just within a span of 8 months, our understanding of the coronavirus have changed tremendously. Even the risk of reinfection, the transmission dynamics through potentially food packaging that are coming in from different parts of the world, those now remain a risk that we need to think about. And the public health policies that we put in place have to change. And this is the reason why that there is a need worldwide for government policymakers to have a very strong collaboration with academia, with the scientists, clinicians, virologists, based on what is the latest science to shape the public policies, the national policies around controlling COVID-19. There is a lot of criticism worldwide by the public, by the international press, around how policymakers seems to be flip-flopping between policies. In Singapore, there were criticisms on the government around our policies on mask wearing, because in the early days, there was a very strong communication from the government that we should not be wearing surgical masks. But now we know mask wearing is one of the most simplest and yet absolutely crucial things that individuals like you and me can do to protect ourselves, to protect our families, and to protect our communities against COVID-19. It is not flip-flopping. It is very prudent policy making based on our latest understanding of the coronavirus. So this is really where the partnership and the trust between academia and government actors need to exist to make sure that the right policies, the optimal policies, are constantly being reviewed and being introduced. Now I talk about talking about how Singapore mobilized such capacity. And I think it's important to first start off with a very brief introduction about primary care in Singapore, because we know that in an outbreak like the coronavirus, COVID-19, primary care globally represents the frontier, the first line of healthcare defense, where if I have a cough, I have cold, I have flu-like symptoms, people typically visit their general practitioner or their primary care doctors. And so it is important to ramp up your capacity in primary care to take care of the population. In Singapore, about 80% of our primary care is managed by the private sector, 20% is managed by the public sector. But what this means is that the clinical response, especially at the very beginning, need to recognize the specific healthcare infrastructure and to mobilize, whether it is the private sector or the public sector, towards a national plan in managing the crisis. So in Singapore, we have a Primary Care Strengthening Act, which we call the Public Health Clinics, that allows even private primary care or private GP clinics to operationalize in a manner that is very much like a government subsidized, government-run primary care clinic, where there is a solidarity in terms of how we treat, the number of the type of medications that is given, the number of medical leave certificates, the number of days of medical leave certificate that is given. All of this is harmonized. And that means there are ways that you can address and pick up people who are infected very quickly. I talk about our clinical response. Actually, since SARS, all tertiary hospitals in Singapore undergo regular drills. We call it exercise Sparrowhawk, very much like a military drill. But that drill has been very crucial in making sure that our healthcare the infection rates amongst our healthcare workers remains one of the lowest. Right now in Singapore, there are less than 10 infections of COVID-19 amongst healthcare workers that are clearly attributed to hospital spread, less than 10. And I see this as a mark of all the preparations that the country has put in place. Now, I talk about strengthening our primary care, and this is where the partnership with private GPs, we call it the public health preparedness clinics. It provides the public with a very well communicated source of information. If I'm ill, where do I go to? And what are the symptoms that I go to some of these clinics? Very much in many instances like fever clinics around the world. And I talk about the use of evidence. This is one of the aspects that we expand our capacity to deal with the number of patients coming in. In Singapore, at the peak of the infection, we saw around 1,000 over cases reported daily. What that translated to was that it would have exerted massive pressure on our healthcare system if all of these people were taken care of and treated at a hospital. But the signs of COVID-19 told us that the vast majority of people that are infected, depending on the age spectrum, would suffer from mild or even asymptomatic infection, meaning most of them have very mild symptoms that will not progress to any severe complications. And we make use of this fact and the science of using technology to monitor oxygen level, whether people are suffering from oxygen distress. We actually place most of the infected people in what we call community isolation facilities. These are field hospitals that have been set up, transforming exhibition halls into field hospitals where people who are infected, but they are mild, they are at the age spectrum that are unlikely to suffer any severe consequence or risk of mortality, people without chronic conditions like obesity, diabetes. These are people that are decanted to community isolation facilities, leaving the precious hospital resources, including the intensive care units, to people who would genuinely have a much higher risk of progressing to complication. And I think by increasing the supply and managing the demand, this has been what contributed to Singapore having a very low mortality rate. So one other aspect is actually redeployment and getting the public to volunteer. We talk about having community swabbing facilities where we run swabbing tests for people, whether it is in the dormitories or whether these are some of the frontline public people. Volunteers in Singapore actually step forward, including the redeployment of air stewards and air stewardess in our flagship carrier, Singapore Airlines. They were redeployed to perform a host of functions that they are capable of in the hospitals, in some of these isolation facilities. Now, our border control measures remain one of the strictest, and I see this as absolutely necessary because importation risk remains the highest risk of why there would be additional spread entering a country. And right now, the country is in the midst of exploring green lane arrangements with other economies and territories that have similarly managed to control their situation well, including, like what Professor Wu has mentioned, Singapore has a green lane arrangement with China. Now, one of the aspects that I talk about in Singapore, it's around our rules on mask wearing, on social distancing. I see the key differentiator in Singapore to be the political will to properly monitor and enforce some of these regulations. And we put in place the necessary penalties for people who flout the rules around even mask wearing. You get fined if you're caught in public without a mask. If you are dining in an area, you need to keep to certain rules around maximum of 5 people per table. And eateries, restaurants who are caught flouting the rules are required to shut down for a period of 2 to 3 weeks until they are able to put in place the necessary measures again. And I see this to be very crucial. I will end off by really highlighting that Singapore's strategies have very much focused on an outcome-based approach. We don't worry too much about the actual count of people that are infected, but we look at what is necessary to prevent deaths and complications to protect our healthcare workers from infection, and making sure that the overall setting is one that promotes a health-seeking behavior and ensuring that businesses, economies, and livelihoods remain as resilient and protected as possible in this very difficult times. So in conclusion, I think I'll end off by saying that Singapore's strategy, very similar to what Professor Wu have highlighted and very similar to many parts of the world, focusing on aggressive testing and increasing capacity for contact tracing, very clear, transparent, and consistent ways of communicating to the public, and not just to the public, even to the healthcare workers and to policymakers in terms of what are the regulations that needs to be put in place around transportation, around disinfection protocols of the environment of workplaces. We look at mobilizing such capacity by managing both the demand, and this is where I talk about decanting mild and asymptomatic infections to few hospitals to be taken care of, reserving the supply of the hospital resources, including ICU beds, for those that require it most. And I end off by saying that it is important that we realize there is a need to monitor all the policies and regulations that we put in place around COVID-19 for safe management of the community. With that, I thank you, and it's a pleasure to be speaking for the APRU webinar. Over back to you.
Thank you so much, Dean Teo, for that really insightful and important presentation. Our next panelist is Professor Julie Leask, who serves as a social scientist and professor in the Susan Owakil School of Nursing and Midwifery, Faculty of Medicine and Health at the University of Sydney. Professor Leask's research focuses on risk communication, responding to vaccine hesitancy and refusal, and strengthening vaccination programs and policy. She chairs the World Health Organization Measuring Behavioral and Social Drivers of Vaccination Working Group and is a member of the WHO Standing Committee on Immunization and Vaccines related to implementation research. And in 2019, Professor Leask was named overall winner of the Australian Financial Review 100 Women of Influence. Today, she will address risk communication and COVID-19. We're so glad she can be with us today. Professor Leask.
Thanks very much, Dean Brookmeyer. So I'll just get this set up. So it's wonderful to be here, and I'm really privileged to be able to speak from the University of Sydney about this all-important topic of risk communication. Risk communication is a field, it's a discipline of knowledge that really came out of the 3 Mile Island nuclear accident in 1979 and has evolved greatly since then, applied to many different case studies, including pandemics. It draws on multiple perspectives, including from psychology, sociology, cultural studies, and it looks carefully at case studies. And of course, it draws on the integration of social science and epidemiological knowledge in particular, but other forms of technical knowledge. We often think of risk communication as this one-way process of experts imparting risk information to the public. And yet risk communication is quite self-conscious in the way it conceives of communication. This one-way process is one important part of risk communication, but it also needs to be thought of as an interactive process of exchange of information among multiple groups, individuals, and institutions. So rather than seeing it as being just one way, it's very much two-way. And you'll see these foundations through the kinds of recommendations that come from the field. But I want to talk about 3 foundations to risk communication first. One is the psychology of risk perception, heuristics and biases. The second is values, and the third is trust. Heuristics and biases are a field of study that has a great deal of research behind it. So I'm simplifying it very crudely here, but I've chosen 3 heuristics that we know can lead to predictable biases in the way we think about risk, particularly during emergencies. And the first one is the availability heuristic, which is the tendency to assess the likelihood, the risk of an outcome, by how readily the outcome comes to mind. So the gentleman you see in the right suffered a meningococcal disease. The public have a lot more fear of this relatively rare disease because of the very vivid outcomes, easily recalled outcomes associated with it. When you compare that, for example, to motivation to have an influenza vaccine, we see a lot more demand for a meningococcal vaccine. The second relevant heuristic is ambiguity aversion. This is where people avoid taking risks when the outcome is uncertain. And in COVID, the uncertainty has been, as it is with any pandemic, a characteristic of the issue, because as we heard earlier, knowledge has evolved and changed as we go on. The third is confirmation bias, which is where strong initial views are resistant to change because they influence the way subsequent information is interpreted and processed. So I've got an analogy here of an Australian bowerbird that collects blue objects from the environment to put around its nest. And for me, that's a kind of a nice analogy that signifies that we'll sometimes choose the blue objects only to furnish the nests of our beliefs. And we're all subject to these biases. It's not just the public, and experts can particularly suffer certain biases. The second foundation to risk communication is the hazard. So often the focus is on the technical debates about what's hazardous and what's not, when really beneath the surface are a whole set of values or moral foundations that people hold dear. So values around protection of the vulnerable, for example, the desire for choice and self-determination, that is one of the values that has really informed the COVID protest movement. The desire for fairness that informs how people feel about different treatments of different groups in inequities. The moral foundation of sanctity, which will affect how people feel about more invasive procedures like a vaccine and what that might do to the body if they hold that foundation strongly. The value of respect that comes up a lot in Indigenous values, for example, and the value of unity and belonging, the need to belong to a social group. These are all really important in thinking about how all of us respond to risk and communicate about it. And finally, trust. Who is telling me this and can I trust them is foundational to risk communication. And Wren and Levine said that you shouldn't really think about trusting me, but thinking about embodying the attributes of trustworthiness from perceived competence through to consistency and empathy. And then Siegrist and Zing have said that in pandemics, salient values and past performance influence trust, and therefore people's willingness to cooperate. Trust is really the most important resource we need in a pandemic, because we need such high levels of cooperation that go beyond traditional ideological or political or other boundaries that exist in societies. So what does this all mean for the principles of risk communication? Covello and others have talked a lot about these principles, and I'm going to just illustrate a handful of them in the subsequent slides. And the first, and the one that is at the heart of good risk communication, is accepting and involving the public. And the reason that this is good is because they are the ones who are subject to the risk, and your messages and actions are much more likely to be relevant and effective. But it's surprising how little this happens in the early phases. And that's partly because it requires organisations to plan before the event, as Singapore did because of the pain from SARS, as we heard about from Dean Teo. And so preparing for a health emergency involves having those pathways to different publics so that you can much more easily interact with them and understand their perspectives. The second that I've added is to prioritise key groups, and we learned this deeply with H1N1 influenza in 2009, where Australia did quite a bit of work with Aboriginal communities to look at improving risk communication, because many Aboriginal people died in disproportionate numbers. And communities said that they wanted to be asked about their perspectives very early on, and then for the information to come, and that the strategies and services needed to be culturally respectful. And this quote from a student of mine who is a strong Gomeroi woman who works and lives in her community and did research around maternal vaccination, it says this: so the service may have spoke to one mum, but guess who that mum has spoken to in the next couple of hours? 20 mums, and she is passing that on. You might not have that flash brochure, but the power and the time that you've put into her, she is putting that into her friends. So having good services where people are treated well can make a lot of difference for their willingness to come back to the service, along with other things like convenience. This has been learned in many different instances, in many different ways, the importance of working with community leaders who are trusted. It's been learned through the pain of having early failures with the way Ebola was managed in Guinea, for example. It's been learned in recovering from measles in Samoa, where I had the privilege of being there for a couple of weeks in January and seeing the staff at the local WHO regional office in Samoa, some of whom were Samoans themselves and had inroads into the community, so could easily work with parents who didn't want to vaccinate, for example, and understand why and try to encourage them to vaccinate with the mass vaccination program that was happening after the large measles epidemic. And so community leaders are really vital, and having them situated within public health organisations can be very helpful. Good leader communication is at front of mind. I understand that soon in the US you'll be hearing a televised debate from leaders or potential leaders. In the pandemic, we've all witnessed the importance of good leadership communication. With risk communication, and particularly the work of Peter Sandman and Jody Leonard, there's recommendations that you communicate early and often. If you leave a knowledge vacuum, it's much more likely for misinformation to go into it. Second, people and their right to self-determination want to hear, even if the information is imperfect. Now, that can be hard for technical people who are used to trying to get good sound information before they share it, before they disseminate it. In those times, there is a lot of uncertainty, and it's recommended that you acknowledge uncertainty. People don't particularly like it, but it's better than being overconfident about your predictions. Tolerating early overreactions is very important. It's important not to misdiagnose early attempts for the public to prepare as panic and respond accordingly, because that actually ramps up the problem. So I don't think mentioning panic is helpful at all. Telling people what they can do now and be realistic and honest and frank and open is important. Showing empathy and communication, sharing dilemmas and trusting your publics. We've seen a very nice example of this from Prime Minister Lee Hsien Loong in Singapore, where so much had been learned from SARS, including about risk communication. This is the 12th of March. This is early pandemic communication, which was realistic. We too face a serious situation. We expect more imported cases. Then he goes on to talk about the clusters in church groups, but warns against stigmatization. He talks about what we need to do now. So this is televised on YouTube and was a prime example of good risk communication in many different ways, as was Jacinda Ardern's communication from New Zealand. Communicating clearly is important. Now we talk about this, but what does it mean? Because it can be quite difficult to do it when things are complex. There's two kinds of communication as I see it in the pandemic. There's communication for understanding, and that includes communicating without jargon, attending to health literacy, focusing on actions. And there's communicating for persuasion, which involves, according to work that's been published by some of this in behavioural science, includes focusing on the benefits and gains of the actions, focusing on protecting others, aligning with the recipient's values, as I mentioned earlier, and appealing to social consensus. Responding well to misinformation, this is a huge issue. Just very briefly, misinformation is a particular problem when it affects people's behaviour. As you saw, for example, in Iran with false beliefs about alcohol curing COVID, and then you're getting children and others being poisoned by methanol. If it doesn't affect behaviour, it's not necessarily a major issue, but it's important to monitor the impact. There's a lot of it, so we need to know what is actually having a reach and what's sticky misinformation, if you like. Preparing people. You might hear people say X, Y, and Z, and so you kind of psychologically inoculate them. So fill the gap early with early factual communication and use trusted people or organisations. Finally, use social science. There's a rich field of knowledge from many different disciplines in social science that have gone to helping us do all of this better, not just communicate well, but facilitate behaviour change as well, which is a slightly different thing. So use social science, and there are many resources available, including a lot of work by WHO, CDC, and other organisations that guide in very practical ways on good risk communication. And in finishing, I'd like to acknowledge Dr. Sheila Basra. She was she really was the face of calm during SARS in Toronto. She died from cancer in 2008, but she's celebrated as a very strong woman who really became an emergent leader during a very stressful time for Canadians. And she's really, to me, a symbol of many of the different leaders, women and men, who have done a marvellous job in communicating during COVID, who hold themselves up as role models and examples of good risk communication. Thank you very much.
Thank you very much, Dr. Lisk. You made such a wonderful presentation regarding to the communication as well as the trust. So our next speaker is Professor Yifeng Zhu, who serves as Associate Dean for Academic Programs at Fielding School of Public Health. Dr. Zhu is a professor in the Department of Environmental Health Science. Her research is primarily in the field of air pollution, environmental exposure assessment, and aerosol science and technology. So her presentation will be on how much protection the face mask offer in the prevention of COVID-19. Dr. Yifeng Zhu.
Thank you very much, Sofon, for the nice introduction. Appreciate the opportunity to talk about our recent work on testing face coverings Well, Dean Tail mentioned wearing face mask is no-brainer and is enforced in Singapore. Unfortunately, that's not the case here in the United States yet. I would like to start by acknowledging two of my students, Li Tiao and Mu Chuan, they both of them did fantastic work in the past several weeks, generating the much needed data for face covering effectiveness in the middle of COVID-19. So some background information. We know human-to-human transmission in the COVID pandemic can go through respiratory droplet. And that is within the 6 feet physical distancing that we have heard many times from CDC and other government agencies. And those respiratory droplets is actually produced not only by coughing, but can also by speaking. In this particular study, we use coughing as a source because that will allow us to quantify enough particles to make quantitative measurements. And there's some literature data suggesting those virulent particles, they're usually less than 5 micrometer in the air. Because they're small size, those particles are very easily to be inhalable into the lung and can stay in the air for hours. The face mask efficiency in terms of filtering out the outdoor particulate matters or dust has been tested in many previous studies. But those studies usually focusing on how the mask can protect the wearer from being exposed to air pollution. However, in this COVID-19 pandemic, as Dean Till mentioned, wearing masks not just protecting yourself, but can also protect your family, your friends, the community. We want to know to what extent wearing a mask can mitigate outward transport of respiratory droplets, especially in indoor different environments. And we want to know with all those face covering options that CDC and other agencies advertise or like to the public, which one works, which one doesn't work that well. So the study has a very straightforward objective. We want to know the effectiveness of different face coverings and how would they reduce the cough generate particles at increasing distance from the sources. And we have 2 hypotheses. One is the particle concentrations will decrease away from the coughing source. And then we expect different face covering will provide a quite range of efficacy to mitigate those particles generated from coughing. So the study was conducted in a laboratory setting. I know this slide is a little bit busy. Let me walk you through. We recruited a subject. This is real subject because we know for the mask to work is not only just the material, but also how nicely the mask snugly fit into people's face. So we recruited real subject and to generate fake coughs. And then we measure particle levels at increasing distance away from the coughing source. We measure 2 characteristics of the particles. One is called particle number concentration. It basically tells us how many particles are there in the air per unit volume of air. And then we also use another instruments to allow us to measure particle size because the size of the particles is an important parameter to determine where the particle goes into our lung and how long they can stay in the air. So we have 3 sampling locations. The experiment starts from 1 minute before coughing starts, and then each cough lasts about a few seconds, and then in between 30 seconds, we generate 5 coughs, and then we post-coughing measure for another minute. Our instruments are real-time instruments, allow us to see the particle levels as a function of time, which I'll show you in a minute. And then we tested 10 different face covering conditions, and as of today, and those are still continuing to grow just because there's so many varieties of different face coverings out there. The experiments were conducted in a laboratory, which is important to have a controlled indoor environment, especially with very low background particle levels, so that we can have measurable differences as we see the coughing can generate relative to the background levels. So here are the 10 different face covering conditions we have tested so far. There's no face covering as a baseline, and we tested face, just face shield only, and then 2 different type of cloth masks, and also in combination with the face shield. And we also tested surgical mask and in combination with the shield. And then finally, the N95 respirator and KN95, those are the sort of like the golden standard that the healthcare workers are supposed to use. So here, just give you an example about a typical measurement session. This is under no face covering condition. And you will see our measurements on particle number levels is on the y-axis as a function of time. Pre-coughing, we're measuring background levels. This is done in my aerosol lab, which is have a very high efficiency filters overall in the room, so we can get pretty low background levels, so that each of the cough, you can see the general specs, and those are measurable relative to the background. And as the cough starts, it took a little bit time for the cough to transport from 1 feet to 3 feet. And then it goes from 3 feet to 6 feet, takes even longer. And the background levels, as you can see, each of the spikes corresponding to a particular cough, and it only picks up and comes back pretty quickly, a few minutes. And one thing to mention is, since we're only using 1 subject so far in this testing, the amount of airflow generated by this particular subject is actually much lower than what we find in the literature. So suggesting some of those coughs may even transport further away if the airflow goes increase for other potential subjects. So we want to summarize, give you an overview sense about how each condition, different face covering condition works. This is the data we collected at the closest location, 1 feet from the coughing source. And what we have done is we subtracted out the background, because the background did vary a little bit from test to test. And then we summarized, we calculate the particle reduction rate. So this is basically calculated as particle number concentrations without face covering divided by width without face covering, and 1 minus that. So the smaller numbers basically showing there's really not much protection going on. And those data indicate how effective a particular type of face covering can reduce the particle generated from coughing. So wearing a shield clearly not gonna protect us very much. And what actually the closed masks, to my, this is a little bit surprise to me, they're actually offering a reasonable protection. We see somewhere 70 to 80% of reduction with even just the closed mask by themselves, or even with the shield as a combination. And then the surgical mask and those KN95 and the KN95 respirators, they are offering a very good protection. The surgical mask, I want to highlight that because this was not always perceived as offering such high reductions, but our data suggests that they are as good as the K95, at least for the outward protection. So here we just want to give you a sense about overall all the data we have collected so far. And again, I want to emphasize the importance for the background to stay low. But even you see the background from test to test, there's still some variations going on. And some of the data are significantly different than the background, some are not. And we summarized all those data into this plot, where you see the 10 different types of face covering that we tested so far, and then which one is significant relative to the background subtracted. So we're comparing that to 0. So without face covering, it's not surprising when you get close to the sources, you get very high level, and they're very different from the background. And as we move down, even with some of the cases where people wearing face, especially the shield only, doesn't really help that much. When you put on the closed masks, it gets substantially lower, but we still see significant results at close proximity to the sources, even in some cases at 6 feet away. The masks, that is surgical mask and KN95 or N95, did offer good protection. We didn't see anything significant when those type of face coverings are used. as I mentioned in the introduction, literature suggests that the jobless, respiratory jobless are like variant latent particles are usually less than 5 micrometer in size. So this is a size that we're showing you the size that we measured from our experiment. So I want to zoom into the cough particles when there's no face covering. And as you can see, the x-axis is the particle size in micrometer, and this normalized concentration on the y-axis. We actually see a lot of particles less than 2.5 micrometer in size. The smaller particle goes, the deeper they get into the lung in general, generally speaking. So those smaller particles will tend to get into your respiratory system easily. And then as those particles transported further away from the coughing sources, we see about 80% of those particles less than 2.5 micrometer can still transport pretty far to 3 feet and still be airborne. And moving further away, then those particles really, the number really reduced by the 6 feet. So the 6 feet in general, I think is a reasonable physical distancing measure to reduce the transmission of COVID-related diseases. And then with different type of face covering, let's see, here are the data. Just zoom in. For those cases, for those conditions where there are less than 90% reduction, that including the face only, cloth masks, and other type of mask in combination with the shield, we see a lot of smaller particles. Those particles are less than 1 micrometer in size. Again, those particles can readily get into the lung if it's inhaled. And then for others, there are, as we move away, those particle levels reduced quite a bit, but still we see quite a bit of smaller particles even at 6 feet with those different type of face covering. For those conditions where the particle reduction rate is greater than 90%, then the smaller particles get substantially reduced, and we see generally there's very few particles that actually can transport further away. Yet still, there are the smaller ones that is more of a concern. So putting all of those data together, we found most cough particles, they are less than 2.5 in the indoor environment. So this is smaller than what we thought was the literature telling us. And as I mentioned, the smaller particles tend to travel further and also get inhaled deeper into lungs. So it's a concern that we need to be aware of. And our protection that we found in this study is the protection that against the cough droplets going out. We found N95 and K95, not surprising, they're really good, offering good protection. And the surgical masks, they are actually doing a fairly good job. And even the cloth masks and the cloth masks in combination with shield are doing, I think, reasonable protection. The face shield only is not recommended. It's really doesn't offer reasonable protection. It's less than 5%. So overall, we think despite a wide range of efficacy, all the face covering we test except the shield only can serve as a simple barrier, and that can help reduce the concentration of cough-generated particles, and that will likely help to reduce the spread of COVID-19. And with all of those, and as Dean Dilto mentioned early, I think the take-home message is very clear: just wear your mask. And if you have options, wear the surgical mask. If the K95 and N95 is still in short supply, but the surgical mask can really help to protect you, protect your the loved ones, and protect our community as a whole. With that, I'll acknowledge some of the funding sources that support this research, and Dr. Q-Hee for volunteering, borrowing us devices to help with the experiment. And if you're interested in any of the papers that is mentioned, here are a list for you to look more into this topic. Thank you.
Thank you very much, Dr. Zhu. This is a really wonderful presentation. So I think I made a good choice. I always use a KN95, which gave me the largest maximum protections. I hope our audience will do the same. So our next speaker is Dr. Timothy Brewer, a professor of medicine and epidemiology at the UCLA. His research interest focused on prevention and control of infectious and emerging diseases in populations and on improving of outbreak surveillance programs. He has been served on advisory boards for World Health Organization, the National Institute of Health, and the Canadian Institute of Health Research, and the US CDC. So Dr. Brewer previously was a vice provost at UCLA, director of global health program at McGill Medical School, and the founding program director for the International Society for Infectious Disease. Dr. Brewer is a past chair of the board of directors for the Consortium of Universities for Global Health. His presentation will be on the California, Los Angeles COVID-19 status and the US perspectives. Dr. Brewer, please.
Thank you very much, Shou Fang. I'm really delighted to be here and talk to you about a response that was not quite as successful as some of the others that you've heard. So let's dive right in and talk a little bit about, I cannot seem to advance my slides. Oh, there we go, okay. Talk a little bit about California and Los Angeles for those of you that may not be familiar. So by US standards, we're pretty large. So we account for about 12% of the entire population. We're larger than Australia or Canada. And in terms of economic capacity, we actually would be the 5th largest economy in the world. So we're actually bigger than France, India, Italy. And we're made up of 58 counties, of which Los Angeles County is the largest and accounts for about 25% of the entire population of the state. And in fact, LA County by itself, think of a county as like a district in another country, is actually larger than all but 9 states in the United States. So we have a lot of people and it's a very, very big, important place. So what happened in the United States? So this is what we think happened. What we thought happened is, gee, somewhere in the end of January, we had a traveler recognized as having COVID-19. So remember, COVID-19 is the disease that is caused by SARS-CoV-2, the virus. SARS-CoV-2 is the virus, COVID-19 is the disease. Shortly thereafter, we recognized our first case in California. We kind of quickly went to a public health emergency. And then in early February, we actually instituted a non-citizen travel ban from China. Shortly thereafter, we actually had a death in Santa Clara County, which is up in Northern California near San Francisco, that we only later knew was due to COVID-19. At that time, it was not recognized. In February 26th, we had our first community case transmission of SARS-CoV-2, also happening in Northern California. And then on March 19th, the state instituted a mandatory shelter at home. And we were in fact the first state in the United States to do that. Unfortunately, the United States quickly became the epicenter of this pandemic, and we are responsible for about 22% of all the cases in the entire world, even though we only account for about 4% of the world's population. So what in fact really happened? So that's what we thought happened, but what in fact really happened? Well, the reality was this virus was coming in much more quickly than we realized and from lots of different directions. So this is a study that was done in early March where they looked at individuals who were coming in with influenza-like illness. They screened them for influenza. If you had influenza, you were taken out. And of the remaining 79 patients, 11%, 9 of them actually had SARS-CoV-2 back in March. So a lot more transmission going on, even back in early March, that we were aware of. This is a study that was done in Southern California. So this is an antibody study. So this top one is an antigen study. So antigen tests are the tests we use to diagnose acute infection. Antibody tests are the tests we do to see who has been infected. And this was a study that was done in early April in Los Angeles County, and a random sample of adults, already 4% of people tested had antibodies for SARS-CoV-2, the virus. This is a study of whole genome sequencing that was done in San Francisco, where they took 36 cases that had been identified with SARS-CoV-2, where they could actually isolate the virus, sequence the genome. And what they found was, in fact, multiple introductions. So this was not a clonal spread. This was not one person bringing the virus in and then spreading from there. So we had virus coming in from Washington. We had virus coming in from New York by way of Europe by way of New York. We had virus coming in from China, and we had virus coming in from places where we hadn't identified where it started. So lots of introduction of virus into the population in a relatively short period of time. So how are we doing? So these are data from last Friday. As of today, we're up to about 7.1 million cases in the United States. As I said, that accounts for about 22% of all cases in the entire world. We're just over 200,000 deaths in the United States. That's about 20% of all deaths. But what I really want you to focus on is the rates. So these are rates per 100,000. So the United States overall, we're running about 2,000 cases per 100,000. California is doing a little bit better. Los Angeles is doing a little worse. And then these are the case fatality rates, also per 100,000. And if you look at the United States compared to European countries that haven't done so well, our case fatality rates are really not that different. So once you have COVID-19, your risk of dying in the United States is really not that much different than the UK, Spain, Italy, other high-income countries where the epidemic has hit pretty hard. Of course, we're nowhere near countries that have handled this well, like Japan, South Korea, Singapore, even our neighbors to the north in Canada. So clearly, whatever we're doing, we're not doing it right. California is a little bit better than the country as a whole. Los Angeles a little bit worse than California as a whole. See if we can explain what's going on here. The other thing to remember is where we really fall apart relative to everybody else is your risk of disease. So if you look at our case rates are substantially higher. They tend to run 2 to 4 times higher, even in countries like the UK that have not done a particularly good job at containing this pandemic. So the big difference between the US and other high-income countries is you're much more likely to get SARS-CoV-2 infection here than you are somewhere else. Now, the important thing to remember is this is a disease of young people that kills old people, okay? So what do I mean by that? The driver of the transmission is young adults. So 60% of our cases, both in the United States and in California overall, are occurring in individuals between the ages of 18 to 49. The problem is they're not the people who die if you get disease. The people who die are individuals over the age of 65, particularly if they have comorbid diseases, hypertension, diabetes, obesity, for example. So the big disconnect right now is everybody says, gee, this is a disease of old people. In fact, not. This is a disease of young people that is killing old people. And that's the important thing to remember. If we want to contain the COVID-19 pandemic, if we want to shut down SARS-CoV-2 transmission, we've got to figure out how to stop transmission in young adults. That's where the bulk of the transmission is occurring. One of the things that we've learned in the United States and in California is that this is a disease of underrepresented minorities, individuals, persons of color. So that if you look at case rates, these are percentages of cases and deaths and percentages of groups, ethnic and racial groups in the population as a whole. So you can see in the United States that Latino, Hispanics, Latinx, and Black African Americans are overrepresented in cases and deaths relative to the population as a whole. Whites and Asians are underrepresented. In California, it's a little closer balance between for African Americans and Blacks, but our Latino, Latinx, Hispanic population still overrepresented in our cases, and our African American Black population overrepresented in our deaths. What's going on there? This is a disease of poverty. And that is true of a lot of infectious diseases. So tuberculosis, pneumococcal disease, many of the measles, many of the infectious diseases that we think about are in fact diseases of poverty. And what you're seeing is the impact of structural racism and inequality in the United States impacting on our communities of color. And so this is where all the poorer parts of Los Angeles are, and you can see this is where all the COVID-19 is. This is where all the more well-off, richer parts of Los Angeles are, much less COVID-19. And as you look at poverty levels by census area, you see our case rates go sky high, as do our mortality rates. Very important to remember, poverty is a big driver of what we're seeing, at least in the United States, California, and Los Angeles. And if we look at the state as a whole, our highest case rates are actually in some of our poorest counties. So remember, think of a county like a district. So Imperial County is out here. The total number of cases are very, very low, but these are rural, predominantly Hispanic county populations in these counties. And basically what we're seeing is astronomical rates of COVID-19. So we're basically talking about going up through the Central Valley of New York and out here in the desert regions of Southern California. So again, poverty, rural, big driver of SARS-CoV-2. We tend to ignore that because the total numbers are very small, but critically important if we want to think about bringing this pandemic under control. So what do? We sheltered at home. So as I said, March 19th, we were the first state in the United States to put in a mandatory shelter at home. Did it work? Well, the short answer is it did what it was supposed to do. So let me take you through what's a very complicated slide. What you're looking at is, so up here at the dotted line is the baseline. So this is what we would expect for people going to work, people going out shopping, grocery stores, retail, people taking public transportation, percentage of people staying at home, and a mobility index. Basically, how far do you go from your house? And essentially what you see is once the shelter in place is put in place right here, all of this drops off. So people stop going to work, people stop going to stores, they no longer take public transportation, and they're not traveling from their homes at all. And their mobility index of 3.8 roughly means that you're staying within a kilometer of your house, to give you a sense. But look at case rates in the back. So this gray is case rates. And I think you'd be hard pressed to argue that in fact this really did anything. And in fact, in Los Angeles and California as a whole, our case rates kept going up despite that. And so one of the things we need to figure out is we really need to get a better handle on what works. And Yifeng Zhu gave us some beautiful data about mask wearing, and there's some meta-analyses to suggest that mask wearing are very helpful. But I think part of the challenge still remains for us is really getting a handle on what does and does not work in terms of containing this outbreak and this pandemic. So now I just want to show you how California compares to a couple of other locations in the United States. So you're looking at case rates basically from the start of the outbreak through till about early to mid-September. The blue line is New York City. The green line is Florida, which we don't think has done so particularly well. And the purple line is California. And these are rates per 100,000. And as you can see, the outbreak hit New York City very hard early on, but they were eventually able to get things under control and keep them relatively under control. In contrast, in California and Florida, we tended not to have as many cases early on, and then we got big spikes, particularly as you got into the summer. Florida a little more so than California, but California didn't do particularly well. So this is June, this is July to August. Again, a couple of big spikes going on there. Things are trending in the right direction, but we clearly have a way to go. If you look at deaths, same story, little harder to see because so many deaths occurred in New York City. Huge spike here in New York City, California and Florida, you're getting these kind of little blips. But to put that in perspective, in California as a whole, we've had about 15,000 deaths from COVID-19. In Los Angeles, it's been 6,500. That's more than most countries of the world. So again, we still have a long ways to go. In the United States as a whole, we're over 200,000 deaths. As I said, 1 in 5 deaths in the entire world documented from COVID-19 has occurred in the United States. Clearly not the best response that we could have had. So where do things stand today? We have a system now in California where we rank transmission based on widespread, substantial, moderate, or minimal. And you can see that those poor rural counties are still having widespread transmission. Los Angeles County is sitting right here. We are as well. This is Imperial County where the highest rates are. Overall, our test positivity rates are down from our peaks of around 10%. So we are having some improvement there. And our case positive rates per 100,000 are also down. So we are making some progress, but still not where we need to be. So how do we respond to this? Those colors refer to what we're allowed and not allowed to do. So basically, church or temple or a mosque, all of that's determined by where you fit on this scale. And so we're, as a state, closely monitoring how we're doing and adjusting our shelter and home and our public health responses based on what we think is happening in the community. Again, not a lot of data to suggest that this is actually the right way to go, but at least at the moment, things seem to be moving in the right direction. So I suspect we will continue to follow this kind of approach, at least for the near future. So with that, I'll just bring it to a close, and we're going to be moving into the question and answer period. Again, I want to thank very much the organizers for allowing me to participate in this fascinating and interesting conference.
Thank you very much, Dr. Brewer. So right now we will move to the question and answer session. So there are a lot of wonderful questions coming from our audience, but I'd like to start by asking all of you the question regarding to the pandemic at this point. As you probably know, the whole world has 33 million patients. And a few days ago, we have passed the 1 million deaths. So my question to the United States and Asia, in fact, has half of the patients and 40% of the deaths. So my question to you is really about the future. So what would be the possibility of the second wave of the COVID-19 in the fall? People say called a twindemic with both COVID-19 and the flu. So what is the chance that we are going to get both? Very high risk for both. And how should the public prepare for this? I think I might start with the team. Tim?
All right, Xiaofang. So 2 important questions. So the first thing to remember is that this outbreak looks very different depending on where you are, right? So what's happening in Australia is very different than what's happening in the United States. And in fact, over 50% of the entire cases in the world are in 3 countries, the United States, India, and Brazil. So you know, those countries alone are driving a big part of what we're seeing. In terms of what to expect going forward from SARS-CoV-2, I think if we look at H1N1 in 2009, 2010, it really took about a year for that to work its way around the world and then become the dominant H1N1 strain that continues to circulate to this day. So from a viral point of view, I think that's what we'll see with SARS-CoV-2. It will continue to circulate probably at a lower level, but it's going to take about a year, maybe a year and a half for that to sort out. In terms of influenza, I'd be very interested to know what's happening in Australia, because they've actually gone through their influenza season. But at least if you look in South America, they had very little influenza. And the reason for that is in countries like Argentina, where they were able to institute effective responses for SARS-CoV-2, those responses actually work for influenza as well. Influenza is a respiratory droplet disease. So social distancing, wearing masks, staying at home when you're sick, and washing your hands will stop influenza transmission. The only thing different is vaccination. Get your influenza vaccine. But if we do everything we're supposed to be doing for SARS-CoV-2, that will likely substantially reduce the community risk of influenza transmission.
Thank you, Tim. Any other comments from our audience, from our panelists regarding to the question?
I think I'll just comment on Australia. So of course we flip our seasons. So we're just, we're in spring now, heading into summer. So we've just been through our winter season. And in our winter season, we've had a much less influenza because of the various COVID prevention strategies that of course have worked on influenza incidents and deaths. We've had a large second wave of COVID in Victoria, in one of our most populous states, but we haven't had that in New South Wales, so we've had a blip. The last day we've had 20 cases in the whole country. So Australia, like a number of other countries, has been very fortunate in our geographic ability to control COVID, but also in the concordance between public health advice and leadership and political leadership. So the influenza season being winter here has not appeared to have an excessively extra effect on COVID transmission, and the second wave in Victoria is probably related to very centralised public health infrastructure, a lack of early, very focused testing and isolating. And once they ramped that up and had a major lockdown, they were able to get that under control, and they're ramping down their control phases now. But it was less about the influenza season and more about public health infrastructure and ability to control COVID. And of course, now that people are able to be outdoors more, and of course, we don't really have a winter in Australia. It's much milder weather than, say, the northern part of the US. But now that we have people out and about, we're probably a little less at risk, of course, because there's just less crowding indoors.
Thank you. Thank you, Julia. Any other comments from our panelists? Okay, if there's no comments, then we move to the second question. The second question is about vaccination, which is something we haven't covered yet. I think people are getting very, very kind of nervous about vaccination. So when would be the time for for high-risk individuals to have a vaccination? When would be the time frame for the general public, and how effective the vaccination would be and what kind of communication strategy we should have to improve our vaccination rate. I think I first go to Julia.
Okay, a lot of questions there. But very briefly, there are at least 200 vaccine candidates and a few of them in phase 3 trials, and things are looking more promising than they were about, say, 6 weeks ago with vaccination. So we will likely have licensed at least one and probably more vaccines with different platforms, some of them novel. And that will create some communication challenges because there will be unfamiliarity for people and there will be uncertainty, even though we've had very large phase 3 trials, particularly with regard to safety. You're not going to be able to detect very rare adverse events. So we need good adverse event surveillance systems and response capacity. And we need to start preparing for the communication now and start communicating now with our publics about what's known about the vaccines and what is not. In the initial phase, the supply will be very limited and there will be more demand than supply. So that's when prioritization is very important. And there are different perspectives to have on that, whether you want to prevent deaths or transmission. Obviously from Professor Brewer's presentation, you know, that will suggest different groups that you want to target. But if, for example, you want to prevent deaths, then vaccine programs will need to initially prioritize older people, people with comorbidities, but also people occupationally at risk like healthcare workers. So all of these issues, all of these trade-offs that are considered in vaccination prioritization and planning, and also what is known about vaccine safety, what is in the vaccines, all of that needs to be communicated now before other voices fill that gap.
Thank you very much, Julia. If we, in fact, there's an issue about vaccination. For example, in the United States, less than half of the people has a vaccination of the flu and other things. People don't believe the vaccination. That's probably a major challenge for the COVID-19 vaccine. And also, there's a possibility, you know, some of the vaccines may not work like expected. So sometimes they have a protection, but they're not that fully protection. So this kind of situation, what should we do? Tim.
So Xiaofang, let's start with, is it technically feasible to make a vaccine? And the answer is yes. What we know is that patients with natural infection can generate antibodies, and these antibodies are in fact what are called neutralizing antibodies, which prevent the virus from getting into new cells. We also know that we can vaccinate individuals and also generate neutralizing antibodies, as well as what are called T cells, which are other immune cells that help to stimulate the immune response to viral infection. So we can generate an effective immune response with a vaccine, as measured in the laboratory. So now we have to know, does that immune response work in individuals? And as Julie said, there are at least 5 phase 3 trial vaccines going on right now to figure that out. The 2 big questions are going to be, how well does the vaccine work? So an influenza vaccine works, typically the efficacy is in the range of somewhere between 30 and 70%, depending on the match and the year. Whereas something like measles vaccine is 95, 97%. So that's the first question, is how well is it going to work? And we can talk a little bit about the different factors that affect that. And the second is, how long will the protection last? So we also know that in some patients, particularly individuals with mild or asymptomatic disease, the antibody levels to SARS-CoV-2 virus drop off very quickly. And the question is, are they still maintaining some protection or not? So are we going to have a vaccine where we have to do it every year, like influenza vaccine? Or are we going to have a vaccine like a measles vaccine, and where we do it once or twice and you're set for life? I think those are going to be the big questions. but we will have a vaccine. I think it is technically feasible to be able to create a vaccine.
So what would be the timeline?
I think we will see candidates probably within the next 6 to 8 months. But I think Julie raised a critical point, at least for the United States. There's been a lot of mixed messaging around vaccines, particularly at the highest levels of government. And that's going to make it very difficult for people to have that trust that she was talking about that's so critical in our public health messaging. So I think that's going to be a huge concern for vaccination in the United States.
Thank you very much, Tim. So my next question would be, so right now, a lot of students are going back to school, and also the face-to-face teaching are starting. So what would be the strategy for the test and tracing to prevent outbreaks? I think this question probably the Dean Teal, if you could comment on.
Thank you very much, Prof. Zhang. So I think in terms of the strategy that universities or schools can employ, it really depends on what is the current situation in the community. The context matters a lot. So if I use Singapore as an example, right now, our students, whether it is primary school, high school students, all of them are going back to school. There are no tests that are conducted in schools because the degree of community spread in Singapore, it's very, very low. Universities, that we manage the classes such that class sizes of more than 50 typically still rely on an online manner, which is like what we have here, webinars. But class sizes that are less than 50, which are many of the tutorials, many of the hands-on practical classes, they're all back in operations. But if I now look at some of the countries where the spread in the community, it's increasing, it's worsening, including some of the countries in Europe, that is where there is a need for the universities and the schools to start to manage their processes very carefully. Do they have a good understanding of the degree of spread amongst the students that are coming back in? Because clearly the last thing you want, it's students, including university students, coming in for classes, and then the university actually becomes the conduit for spreading. And some of these people may go back home, interact with their elderly parents, grandparents, and then spreading it to the vulnerable segments of the populations. So in those situations where the community spread becomes more substantial now, there are difficult choices to be made, because when we talk about even deploying tests, mass testing sounds great in theory, but in practice, there are all sorts of problems in how you implement a mass test. And mass testing doesn't, you don't implement it just once off, it has to be repeated testing as well. So when you run those kinds of tests, false positives, false negatives can occur, and are all the positives that are identified subsequently tested again with perhaps a more accurate PCR swab test. And that brings in a lot of capacity issues. And some of the strategies that we talk about right now in California, in Singapore, in Australia, in China, actually will not be relevant for some of our attendees as well. Our audience, I saw a question from Andrea that were asking about the situation in Colombia. How would some of the solutions that we have, including mass testing, including learning from home, starting at home, using Wi-Fi based approaches, those options may not be available. So I would say it's hard choices, but at the very basic, some of the community measures on safe management must be put in place, and those will be very simple measures that I talk about. And our colleagues have repeatedly mentioned, wear your mask. Wearing a mask has been shown clearly that it helps manage the infection within households, within communities. And in my university right now, every faculty member, every administrative staff, and every student has to wear a mask. If they don't, they are not allowed to come into the university. And in fact, in Singapore, if you don't wear a mask, it is a national offense. You get penalized for it. So I think simple measures like wearing a mask is the very basic thing that individuals can do. Back to you, Prof. Chan.
Yeah, thank you very much, Dean Teo. So I have another question, which is a quite interesting observation. I trying to put all mortalities of the Asian countries, including India, and India, Singapore, South Korea, Japan, so all of the Asian countries, and also I put the mortality of all, the Western countries, including European countries, United States, Canada. What I found is very interesting because the Western countries, the mortality is about at least 10 to 100 times higher than the Asian countries. There's huge difference. So what is your, explanation about this difference? This is a really big difference. So I want to hear from you. I think Dean Teo.
So over here, I would say that firstly, all countries in the world receive the same advice and recommendations from the World Health Organization. So it's not as if the Asian countries have received special instructions that made our control better. We receive the same kind of instructions from World Health Organization. What are the measures that are necessary? What are the procedures and processes that governments, policymakers can put in place to protect the community, to minimize infection, to break transmission chain? Those instructions are the same, but what is different is always the context. The context matters a lot. And I will mention 5 contexts if I can recall all 5. The first, of course, is the historical context. Some of our countries and economies, including Hong Kong, Taiwan, Singapore, China, we had very bad experiences with SARS, with MERS, including Korea. Korea had a MERS outbreak. All of that gave us a historical perspective of how important it is to protect the people and the country. And that directly translates to the economy. Historical context, very important. The second is really the cultural, the social context. What work in a country like Singapore? I talk about the use of enforcement in penalties. It's a cultural context that we are in an environment where this is very much ingrained in how the society in Singapore functions. Some of the issues that I talk about, having very strict penalties on restaurant, eateries, individuals who don't wear their mask, may perhaps lead to very bad protest against the policymakers, against the government, if they are enforced in a strict way in some Western societies. So the culture, societal context matters. The third is actually the technical capability. And I mentioned some of the well-resourced countries have capabilities that the poorer resource countries are unable to deploy the same kind of technical and resource investment. The fourth is economic. Singapore, we had the privilege of having a lot of foresight from our forefathers to build up national savings. So with the national savings, the country can put in place economic response that helps. The last, which is what I will highlight the most, is the political context. The political context matters because how a government respond during peacetime. Did they put in place the necessary investment to build up the infrastructure, the right mindset towards pandemic preparedness? Matters a lot. Public health, I would like to mention, public health is always one of those aspects that during peacetime, governments don't really think too much about it. They would rather build hospitals because from a vote-winning perspective, that gains them a lot of votes. Trying to put in place obesity, diabetes prevention program, that is years before you see the outcome. So having the political leadership to invest in the necessary public health infrastructure is very important, not just to infectious diseases, but also to communicable diseases. And over here, I would also like to highlight just one point. And this is something that all of us perhaps may need to reflect a little bit on. Academics, global health academics in November last year published a global health security index that actually ranked the United States as being number 1 and United Kingdom as being number 2 in terms of pandemic preparedness. What happened to academia to come up with such a mistaken index? Because right now, clearly, when there is a real pandemic happening, we see from the outcomes what genuinely has happened. And I think this is where we have to reflect a little bit. Is there a disconnect that is happening right now between academia and the real world, especially in global public health, that collectively, including in the APRU community, we need to think about collectively? Back to you, Prof. Chow.
Thank you very much, Dean Teo. Let me use our, the very senior professor, Roger Ditters. He has an explanation. He said Asian people put the community first, and Western countries put freedom first. I think he makes this kind of statement. I think this probably be true to make this kind of difference, especially in the pandemic. And so let me move on to the next question, which is right now. I think a few days ago there are a lot of news come on, on the media regarding to the D614G mutation of the virus, which actually can increase the ability to transmit it to the people. And some people say maybe the face mask is no longer useful, and washing your hand may not be prevent the disease. I'd like to ask the panel's opinion. Maybe start with Yifeng. Dr. Zhu.
Thank you, Zofeng. The face mask, they don't kill virus per se. They protect the virus from getting into your lung. So from that perspective, it's really how the efficiency of the face mask and how you wear it, how snugly it fit into your face to eliminate the particles from and the cough droplets from getting into your respiratory system. Right? They won't kill the virus that they collect on the surface of the mask. So from that perspective, it doesn't really make big difference what type of a virus are attached to those cough droplets and other respiratory droplets.
Okay, thank you very much, Yifeng. So my last question for all panel to answer is how long will COVID-19 be with us? And when can we expect to be back to normal? Tim.
COVID-19 is not going away anytime soon, at least in the United States. I would say we're looking at least another 6 to 8 months, but it wouldn't surprise me if we're talking about a year to 18 months before we get back to where we truly were before, and with the caveat that if we do get a highly effective vaccine, that could substantially change the time frame. But I think based on what happened with H1N1, we're looking at probably about a 2-year cycle.
Thank you. Any other panel members? Teo, yeah.
I'm actually a little bit more pessimistic because based on what we see in terms of vaccines, especially for coronavirus, and some of the modeling results that colleagues have been producing, I fear that some of our safe management measures like mask wearing may be with us for a very long time, even after a vaccine is available. And even with the COVAX facility, right now, guarantee of 20% vaccine supply to each economy and each population means that many countries will have to wait a while before they can get to that 60-80% vaccination supply for the vaccination doses for 60 to 80% of the population. And I think Tim mentioned that 18 months to 2 years, that is perhaps a realistic target for us to get the necessary doses of vaccine. But Tim has also given us a very important caveat. How long does the vaccine last? If a vaccine needs to be renewed every year, meaning I have to take the vaccine every year, the world would be facing COVID-19 for a very, very long time, and we would probably be wearing our mask for a long time as well.
Thank you very much, Dean Teal. Julia.
Thanks. So, you know, there's three scenarios really. There's in which we control COVID. One is through herd immunity, which is looking very unlikely. One is through the virus changing and becoming less virulent. And the third is good vaccination coverage with an effective enough vaccine and a safe enough vaccine. And I think the vaccine is our greatest hope. So we'll get, ideally in early part of 2021, we'll get some early doses coming through if the phase 3 trials are successful. And then it will take quite some time to both produce enough vaccine to get sufficient coverage to distribute the vaccine and make sure it's accessible to all people. So equity of access is very important here. It's not just about the way we're convincing in our communications as well. So we're going to be living with COVID for a long time. Will it look exactly like it looks now? No, there will be changes. And I think as we go, we'll be learning more from the evidence like that has been presented today and other evidence on what works in controlling COVID. So we'll get that calibration of strategies a bit more fine-tuned, and then be able to live with COVID with both different kinds of control strategies and then the vaccine hopefully coming through. So you can't answer this question with certainty. And it's one of the points I made about communication is acknowledging uncertainty and not being overconfident with predictions. But we are very much hoping that things will start to change throughout next year. But I think we'll be living, I agree, we'll be living with it for quite a long time in one way or another.
Thank you very much, Julia. We're going to have a new normal anyway. So Yifeng, do you have any comments?
Yeah, I just want to echo what Zuofeng you just mentioned. No matter how long we have to live with COVID, after post-COVID, life won't go back to exactly pre-COVID. Many things will change. Maybe something will change for good. Environmental climate field, we see overall there's lots of less carbon emissions during the pandemic, and people commute less clearly, and there are lots of things can be done remotely, save carbon emissions. There's things that I think the whole society, the whole world needs to reflect on, and the world will be different post-COVID.
Thank you very much, Yifeng. So we are nearing the end of our time, but I appreciate all of the thoughtful questions we have received. Some of the questions already being answered by our panelists, and some of the questions being publicly discussed. I want to thank Secretary General Chris Trim-Wan, UCLA Chancellor Dean Brookmeyer, and all the speakers, Dean Y.Y. Teal, Doctors Zunia Wu, Julia Lisk, Yifeng Zhu, and Tim Breyer for being with us. Thank you for sharing with your expertise and how COVID-19 is impact in the Pacific Rim region. And thank you so much for joining us. And please visit our website, ph.ucla.edu, and APRU's website at apru.org for additional information, including COVID-19 related resources. And we're going to have a second, third, and fourth webinars. It's going to be announced very soon. We wish you continued good health and safety. Thank you again, everyone. Have a good rest of the day or evening. Goodbye.